I would like to extend my greetings and congratulations for all organizing committee, scientific committee, all active and working groups, supportive companies for achieving this great event and giving us this opportunity to share the scientific experience with our colleagues from all over the globe. Actually, there are just to mention and I'd say that I should mention that most of my cases, I am insisting to do most of my cases through the distal radial approach, and distal radial, right radial approach, not left radial approach, even in primary PCI. This is number one. And the second thing is that in primary PCI, I'm using one catheter, mostly Tiger catheter from the beginning. I'm not using diagnostic catheter. So this is the first case, is a 70 years old female. She's not diabetic, but hypertensive since 2000. 2 days history of resting ongoing chest pain with positive troponin, ECG, dynamic STT changes, and echo reveal anteroseptal hypokinesia with good ejection fraction. She was already on clopidogrel, aspirin, Crestor, enalapril, beta blocker. So diagnosis of non-ST elevation myocardial infarction has been made, and the patient admitted for early coronary angiography and possible intervention. Coronary angiogram was done, and that was the left system. We can imagine this is the available view of the left system. So this is a bifurcational LAD, critical lesion. And that was the right system. Anything missing here? So can we go directly to the BCI? Circ. So there is absent of the circ. So what's next for this? Because we are looking for the area of the myocardium, the posterolateral aspect is bared and not supplied by vasculature. That's why we are insisted there is something which is missing. There might be a total or subtotal or diseased circ or aberrant anomaly. So where is the circ? And that was the view of the circ. And now, how can we decide, is this a critical, distal, or ostial circ? So the decision also become a little bit complicated, but we can look to the views, and we insist to do a more clear for this ostial and the distal. In that view, it appeared that a little bit the ostial circ is functioning and its lesion is below the expected critical, and the decision was made to do the PCI of the, mainly we regard the culprit as the LID, and the procedure progress in a usual way, provisional stenting, and the patient discharged after 1 day, and on follow-up after 2 months, the patient was free from symptoms and doing well with no ongoing chest pain, and that's the story of this lady.
So that guide was what? Was Tiger?
No, that was not Tiger. That was not Tiger. The second case, this is a strange case. This is a 35 years old male with no previous history, not known, and he was driving a taxi, and our center, private center, is on the side corner of the street, and he is hitting the door of the street, and the medical staff thought that this patient is a drinker or something, and they regard him as an epileptic, has an epileptic fit because he is young. No, they didn't know him. But resident doctor immediately did for him resuscitation and put him on monitoring and withdrawal of sample of blood with ECG. It was an extensive anterior myocardial infarction, and the patient was in state of fit. It was a ventricular fibrillation, recurrent attack of ventricular fibrillation, and he was resuscitated with multiple, many DCs, and the cath lab is immediately activated, and during activation of the cath lab, also, this is the right system of the patient. You can imagine the LV function is still good, and this is the right coronary, and that's the left system.
And dynamically, patient is stable here or not?
No, his blood pressure is 90/60, and also our approach, although despite that the patient is. So what's next for this huge thrombus burden, and the patient is a little bit in hemodynamic and electrical instability? Can we go to the thrombolytic and abort the procedure, or refer the patient for surgery, or proceed to thrombus aspiration or direct stenting for this lesion despite this huge thrombus burden?
See.
Okay. So the decision was to do balloon daughtering of this patient and direct stenting, and that was the result. Anything also? CIRC. After 3 months, we did a CT angio for the, we didn't concern about the CIRC at that time. I did CT coronary angio for the patient, and he was very good, and he has separated osteo of the CIRC, and it was functioning rudimentary CIRC that was written in the CT scan. So what is the home message? In acute coronary syndrome, many challenges can complicate the decision, especially when the culprit is not so confidently recognized. Aberrant coronary origin is one of the rare anomaly and can mix and mask the picture in acute coronary syndrome. And one should be, interventional cardiologist should be fully conscious regarding the area of myocardium, which was not so directly supplied by the blood vessel. Direct stenting with avoidance of over manipulation can work and give excellent result, not in all cases. Distal radial approach is my preferred approach, even in most difficult scenarios. In a critical situation, I use one single catheter for the engagement of the right and left system, and thank you very much.
Excellent, Doctor.